that with you. It is important that, especially when you're training, to get used to CPT codes and ICD codes and everything, but it's also important to understand where some of these specialties come from and what's involved with the specialty, so that when you get out there in the real world, you know what to expect. Because I was recently reminded that coding for book learning and testing and stuff is a whole lot different than real world coding. So I want to give you a little bit of both tonight and share those with you, some things to give yourself a heads up and to do some more research. Maybe you would have your notebooks ready. I always say it's a good idea to have a little spiral notebook or a little notebook where you can jot down some notes and some things that you might want to go and do some more research in. Okay, so the question was, what do I need to know to work for an ENT? And ENT stands for ear, nose, and throat. It is a specialty. Let's see, it's otolaryngologist. These are physicians. They are doctors. You could be an MD or a DO, and it is working on a specific area of the body. So just like you would have a cardiologist that is going to work on the heart and supporting vasculature, then you might have a neurologist. They're working on the brain, but it's also the nervous system, the PNS and the PNS and CNS that runs through the entire body. Maybe you have an endocrinologist, and that would cover lots of glands throughout the entire body. So an otolaryngologist, and oto stands for ear, larynx is for the larynx, and the go is for the glottis. That is your tongue. But they also cover the head and neck, different structures in the neck, not just the organ systems. But we don't, of course, say otolaryngologist, we say ENT, because everything we do in the medical field is abbreviation, right? We don't want to say those big, long words if we don't have to. So let's talk about some of the body systems or areas that we're going to be looking at when we work for an ENT. One of the most common ones is going to be the sinuses. Everybody has problems with their sinuses, it seems. And it doesn't have to just be that runny nose or that pops up once in a while when we get a cold. It also can involve things like suffering from allergies and hay fever. I'm in Texas right now, and they have this thing called cedar fever, which, I'd never heard of until I got down here, which would be like hay fever. It's when the cedar's popping or doing its thing. And so sinuses. Now, the word sinus actually just means cavity, if you didn't know, but that's what that is. The sinuses in this part of your head and up here in your forehead, they're just cavities in there, and they get inflamed and they can get filled up with different things and cause that puffiness and being miserable. They can get infected and stuff. So sinuses is something that the ENT is going to often be seen for. The larynx. Now, if you're not familiar with your larynx, it is in the lower part of the throat, and the layman's term for that is your voice box. So once, maybe twice a year, I get laryngitis. Doesn't happen very often, but at least once or twice. And everybody teases me that, oh, doesn't that make your husband happy? Well, yeah, no, I like to make everybody miserable if I can't talk, because as you know, I get paid to talk for a living, and I do it well. I enjoy talking. So laryngitis, but any other effects or things that can affect the larynx. You can have polyps. You can have deformities, as well as inflammation. When people are voice actors or singers, their larynx is something that they're very concerned about. My number 3 just happens to have laryngitis today. She woke up this morning and she came in and was telling me, I can't talk. What happened to my throat? And she's been having all this sinus drainage, and everybody's been suffering from this viral thing that's going around. It's like, yep, that's what happens to some of us. So the larynx, and really interesting to see the larynx in action. I'd encourage you to go out to YouTube and type in larynx, and it looks like a little triangle, and then it opens and closes, and that's how you get different sounds. So it's pretty cool. Oral cavity, so that's everything inside the mouth. You know, what we think of, layman would think of as the mouth, everything that you can see. So that would include the gums, the tongue, the palate, and the bussol, it's B-U-S-S-O-L or A-L or something like that, your cheeks, and lots of things that can, you know, cause problems there. They don't think and get them confused with a dentist, because a dentist would specialize in the teeth, of course, and other things, but a dentist isn't going to treat you for strep throat, right? They're going to send you to the ENT or your PCP. But everything in the oral cavity, maybe there would be the tonsils, you know, having problems with the tonsils, or having cancer of the tongue. Again, the ENT would be involved in that. Upper pharynx. Now, the pharynx is the back of the throat. And I should have put a picture here, but you know what? I saved for some really good pictures that we've got coming up. Boyd and I were discussing them just a minute ago. So the upper pharynx, again, you think of from like the behind the tonsils, the back of the throat, and looking down. And of course, people that have recurrent things like sinusitis, rhinitis, that is going to cause the upper pharynx to be swollen and inflamed because of drainage. People that have problems with their tonsils, that may need a tonsillectomy or an adenoidectomy. Again, that's the upper pharynx. Then we don't want to forget the neck. There is some musculature type stuff, cervical, spine. Now, of course, they are not going to treat the cervical spine. Or let's say you have a problem with pain in your neck. You know, again, they might be able to identify a problem, narrow it down to that, and then refer you into musculoskeletal, somebody that specializes in that, or therapy for physical therapy to help with the neck. The face, so again, we're not talking about the integumentary system, like if you have blemishes, but let's say they see something that they think, oh, this might look like a squamous cell carcinoma, you know, or a basal cell, or again, different things on the face, the way that the mouth forms to make words and stuff. And again, there's other things that can happen to the face that that they may address. And the ears. Lots going on with the ENT for the ears, which I've got some great pictures for you coming up. Maybe you like to go jump out on YouTube and see the people having their ears cleaned out. I'm not one of those people that produces hardly any wax in my ears, but my children sure do. And so on Saturday night, I used to go and make sure that they had, when they were little, that they had clean ears. It got to be a kind of a thing where they'd all lay down and I'd look and make sure their ears are clean. So again, it's hereditary for the most part. Your ears produce wax or cerumen, and that can cause problems. But not just that part of the ear, we also have hearing loss. So they're an integral part of helping to diagnose and treat with hearing loss. They work with audiologists a lot, and it's important to note, which when I was doing the research, hearing loss affects 1 in 10 North Americans. I thought that was really kind of interesting, you know, and that's not saying that you're clinically deaf. You can have all different types of hearing loss. You can lose low tones, high tones. You can have tinnitus, which is ringing in your ears, and that can cause you to have deficits in your hearing. You can have senile hearing loss, which just means you were just getting, you know, the organs of the ear, the structure of the ear is wearing out. You can have congenital deafness. Again, you could have worked on a ship that did, I know there were some guys that were in the Navy, and they said, yeah, working with all that equipment and stuff on the ship, and that's why they can't hear. So, you know, being deaf or hard of hearing is very, very common. And in fact, the number 3 language in North America is ASL, American Sign Language. So you have English, Spanish, and then American Sign Language. So that's kind of interesting to know. So those are the main parts of the body that the ENT will be looking at. Now let's look at some of the subspecialties or specialties that follow an ENT that, you know, so you could be a neurologist, but you could be a pediatric neurologist, right? So again, I think it's important to understand that you may have an otolaryngologist, but they may be a subspecialist. The otology or neurotology, that's going to be anything that has to do with the ear, and that could be hearing loss, like we mentioned, trauma to the ear. Maybe you you were close to an explosion or really loud noises and you blew both eardrums. It could be cancer. It could also be things that have to do with things like Meniere's disease, which affects not only hearing but balance. What do they treat? Pretty common stuff, but the ear infections, otitis media, swimmer's ear, then you have pain that happens in, you know, the face and the neck. Pediatric specialty is, again, doing ENT from birth to whatever they consider out of pediatrics. It used to be 18, and then there were some other things that it was like 22, I found out, but it's not necessarily pediatric. I do know that there was a particular YouTube person that had said even though they're like 26 or 27, they still saw their pediatric specialist because they have a rare disorder, and that provider had been treating them since they were like 2, and so they got permission, special permission, to continue to follow their treatment. So that was kind of interesting. So a lot of ear infections, development. I know that one of my children saw a pediatric specialist, otolaryngologist, when they were worried about his ears, and everything turned out to be okay. And I've got a couple of my grandchildren have gone in and seen pediatric ENTs for hearing loss, and we've got lots of people with hard of hearing and different types of hearing loss and deafness in our family. So some other things that they could look, you might be seeing that people visit, would be Down syndrome and allergies. Of course, some other types of congenital malformations or syndromes, they will be treating, because again, they notice it at birth, and people that have Down syndrome, just the structure of the head, the skull, the face, and some other anomalies that happen in the structure affects Down syndrome. And they do have troubles with their eyes, their ears, and their noses. And of course, allergies in children. Head and neck specialists, tumors, maybe thyroid and parathyroid. Now, they would maybe be working with an endocrinologist, but if this is something that they specialized in, they might do surgical procedures on the larynx too. So again, a subspecialty. Facial and plastic reconstruction, cosmetic procedures, reconstructive abnormalities, people that have problems with their nose and they have to have a rhinoplasty and things. They could be a ENT with a specialty in plastic surgery. Deviated septum is something that you see a lot. Rhinology, again, nose and sinuses. That's what they specialize in. Laryngology, again, will be the voice, swallowing problems, people that have problems after a stroke or an injury. Also, you wouldn't, you might not think about it, but people who have GERD will often have problems with coughing, and not just the regular heartburn, but they can have swallowing problems and other issues that you may not have realized is associated to GERD. So the ENT would help with that, and also probably a gastroenterologist might work together if somebody had a severe problem with that. Allergy specialist, they may be an ENT that works with allergies. And again, some of the same things we've already stated, but ear, nose, and throat absolutely are affected with allergies, as well as your skin. But it seems like when people say, oh, I'm suffering from my allergies, it's the ear, nose, and throat, right? And the eyes. So now I want to talk about some really common CPT codes. Now, I could have spent a long time on ICD, but the truth being said is that to me, the diagnosis component of ENT is pretty straightforward and easy. However, the CPT to me is a little more complicated, has a little higher learning curve, I think. We do want to make sure that we understand that our CPT codes right now is how you're getting reimbursed, but it's your ICD codes that are showing medical necessity. Okay, so why would you do a procedure or do this type of evaluation? Because of the diagnosis code. And when we looked at all of the different things that our ENTs could be focused on, it really opens up a lot of codes. We're going to have G codes. We're going to have codes for, we could have some S&T codes, some trauma codes for injuries, but we're going to have R codes for signs and symptoms, absolutely, right? And let's see, I'm trying to think of some other ones. M codes for having problems with the malformation of the jaw, TMJ and stuff. Also, I mentioned that the ENT will work with a dentist, but also an orthodontist, because you can have TMJ, some problems with this joint, as well as union of teeth, and maybe too many teeth causing problems with headaches and stuff that might be diagnosed by the ENT, and then they'll refer you to the dentist or the orthodontist. We got some questions. Let me look over real quick. at the questions before I get into 92567. Whitney says, ENT physicians have to treat conditions that teeth problem cause. For example, teeth grinding causing joint problems and such. Absolutely, you're right. They might initiate treatment or be involved with the treatments, but then what they're going to do is they're probably going to do a referral to an orthodontist or a dentist to have further treatment, and then have them come back like in 3 or 6 months to see if that took care of the TMJ problems or the headaches that they might be having. She says, I saw a patient the other day in the peds. The patient was 21 years old, so I guess they still count peds there. I was really surprised, and not to get off on a sidebar, but pediatric BMIs, go look up those. They don't stop at 18. Okay, so we are going to look at one of the CPT codes that you're going to see quite a bit, 92567. This is for tympanometry, and try to say that very fast. You'll struggle with it. I don't even say it in my head. I look at it and my brain says Timpy. I don't know why, but it's you're looking at the tympanic membrane of the ear, which is the eardrum. Okay, so that's where they're getting this. We're going to evaluate that eardrum and the function that's happening with the flexibility of the eardrum, because it's a drum. I mean, that's how it gets its name. So you know how the diaphragm, the piece that's pulled over a drum, when you see somebody hitting it with their hand, I mean, that is kind of the same thing that your eardrum does, and thus it gets its name. Uh, but aren't we glad it isn't like a snare drum, right? And like one of those ones that are shaped different. You see that piece of leather or whatever they use to strap over the top, and they hit it. Yeah. So evaluating the middle ear, we're looking for dysfunction. A lot of times it'll show, we might see fluid. We could see negative pressure. We could have rupture of the tympanic membrane and disruption of the oocials and otosclerosis. I see that a lot come up, the otosclerosis. Remember, auto means ear, and sclerosis is kind of like hardening. They'll examine with an otoscope. That's how they look in the ear. And then there's a couple of different ways they do this, but they put this little device in the ear. And here's a pediatric one where they just place it in the canal. Sometimes it's part of an otoscope, and it's the end part of the otoscope, and it'll do it. And they put a little pressure, and it watches the tympanic membrane and how it moves. And then it's recorded, and then tell if there's a problem. So this is extremely common with ENT treatments. Know that there is not laterality with this code. So, if they do one ear or they do both ears, it doesn't matter. You don't have to put a modifier 50 on there. It's just they do it. So that's something to think about. 92504, binocular microscope. Now, this is a procedure as well, and it's diagnostic. So what they're going to do is they're going to use what we would think of as that microscope, and it's binocular, meaning they're going to have two things that they can look through, not just one. That's what that means. And they're going to look in the ear. They can look in the mouth as well, but they're looking through a microscope. They're really looking at and amplifying something. If you've ever gotten to use a microscope, they're so much fun to use and play with, and they're pretty affordable now for some simple ones. It's fun for the kids. But the thing is that they have two eyepieces that they can look around and see the structure and make sure that it's not structural problems or abnormalities that they're dealing with. Pretty common for them to go in and look at this, especially when it's a new patient. Now, this also does not have the laterality. Yeah. Very, very common code is going to be an endoscopy, nasal or sinus endoscopic, but I wanted to bring up one that was a little bit different first. This one's to control nasal hemorrhage, which is called epistaxis, and that's a nosebleed, epistaxis. That can happen for many reasons, but part of it can be allergy. You know, the nose, the sinuses and the nasal passages, they dry out because of that constant irritation that they're getting. You know what it feels like on the outside of your nose when you get a cold, and now they've marketed, you know, having Kleenexes that have, you know, tissues that have lotion in them because the outside of your nose gets red. Well, if the outside of your nose gets red, can you imagine what the inside of your nose, nasal passages and sinuses look like with that constant movement of irritation and swelling that's in there? So again, this is a specific code because we're going to control epistaxis or nasal hemorrhage. And I wanted to point that out. We are going to look at a nasal and sinus endoscopic code, but this one is unique and that's the purpose. So we don't want to get those confused. And this is what that endoscopic tool looks like, and it gives, they go in and they numb that, and then they insert that and they can see if there's any bleeding or hemorrhaging or what's the source of this epistaxis. You know, why do we have, is it because there's trauma? Is there because there's an injury or irritation, or maybe there is a cancerous lesion or just a lesion in itself, you know, and why is that lesion there? So they go in and visualize. You know, you can't treat what you can't see. And so I thought that it was funny that this little boy had a smile on his face. But the picture that you're seeing here is not dealing with any type of a hemorrhage, though, but you can see that there's edema or swelling, and there's pus there that they're looking at. And then also there can be polyps involved. So I thought that was an interesting, that was such a good graphic that I almost used it twice, but I luckily caught myself. So that is that endoscopic procedure might be used more than once as they're healing, you know, but it is only looking at the sinuses and the nasal passages. So if we want to go farther and look at the back of the throat or the larynx, we're going to do a laryngoscopy, flexible and diagnostic. Now, there is more than one. There is one that is not flexible that usually gives a better image. However, I think that a lot of times the flexible one is what we see in the ENT's office more often. And remember, this code is diagnostic. So we're looking to identify something. We're not, whereas the previous code, we're visualizing, but we're doing something in addition. We're controlling bleeding. We're controlling a hemorrhage. So 31575, extremely common, no laterality in this, because we're going to go and look at, you know, we don't have laterality. However, you know, when this procedure and the other ones that we've talked about, those would append a modifier 25 on your E&M code probably. So what is the diagnostic laryngoscopy used for? Well, it's going to be used for visualizing the larynx or the hypopharynx. So down below the you know, past the tonsils, the lower part of the throat. Remember we mentioned earlier upper pharynx. Now we're going to go a little bit farther, and this was an image to show you. They go in through the nose. Well, they numb everything up. Very important. Then they will insert the tube, and then that will that flexible tube with a camera will go and visualize the larynx. Okay, they can go all the way back to the larynx and visualize that. They could even have you try to talk or sing because they want to see the larynx in movement, the vocal cords actually moving to see. Maybe they're not closing properly. It's almost, when you first look at one, if you don't know what it is, it even can look sometimes when it's moving like a valve in the heart. It looks kind of like the tricuspid valve. But it in a way it is kind of a valve, but it doesn't serve the same purpose. But that structure and movement, that little triangle, is very similar. But then when you see it and you realize nothing's going through and it vibrates too, it doesn't just open and close. Whereas the tricuspid valve, it's a constant movement, right? And it's helping to push a liquid, push blood through. So again, this is a very, very common code that you'll want to look at and maybe go in and watch some of these procedures being done. YouTube's a great place to look. You can also go to OR Live, but remember that for this ENT purposes, we're looking at the provider's office versus surgery. So that's kind of the way I'm focusing it. But absolutely, go out and see if you can find some more information. Oh my, cerumen impaction. This, I like to laugh at myself and tell myself this has got to be the bread and butter of an ENT. I mean, I wonder how many times they have to clean out the earwax, the cerumen out of somebody's ear. It would be funny. You could say, oh, if I could have a nickel every time they had to do that in the day. Let's see. Oh, another comment. What about removing foreign bodies from the ear and nose? Yes, absolutely. That would not be diagnostic, though. They would go in, but the code changes if it's not diagnostic. Right. ER doc is unsuccessful removing foreign body and refers to ENT. I've seen that happen a lot. Absolutely. There's some pretty cool ways to get a foreign body out of a kid's nose if you've seen them do it. If you've ever gotten to work in the ER for any significant amount of time, you're going to get a kid that's put a bean up their nose or in their ear or something. Legos, not so much. They're square, most of them, but now they're not all square. But beads, but the worst is beans because they swell up and they start to ferment and it's nasty. Whatever they stick up their nose, if you don't get that out pretty quickly, it's pretty foul smelling. Okay, so removal of impacted cerumen. Now there's two codes actually that you want to pay attention to. 69210 is the one that I chose to pull out because it's using instrumentation. However, 69209 is if we irrigate or use lavage, which is using water to clean out the ear, some type of a liquid. And this is what you'll see a lot of the other doctors that aren't ENTs will do that, right? But if they can't do it, they will probably refer you to an ENT and then they'll do a 69210, right? So pay attention that you don't code a 69209 when instrumentation was used. This also has laterality to it. So are we are we removing impaction from both ears or one ear? And this one's unilateral. And of course, you can append a modifier on there to tell them that it is both ears. If you didn't know more about cerumen, it's not just earwax. I thought that it was interesting. The Find a Code is where I got all this additional information. They're brilliant. I love using Find a Code, but they had made a point to say it's lipids, so it's little fatty cells, sebaceous cells, auditory canal will get buildup and debris. A lot of times you'll see hair in there. And what it is it's protecting the ear by catching things, sticky things, using the stickiness so that it doesn't injure the tympanic membrane or the inside canal. Just like if you see a flower and you see bugs that'll get in there and it sticks and spreads pollen, you know. But also you might see that there are different flowers, flora and fauna that eat bugs and digest them and stuff. And I always think of that earwax because it sticks it, but it catches it so it can't do more trauma to the inside of the ear. That's kind of why we have earwax. Uh, Other problems can be caused though by too much earwax or a buildup or impaction of earwax. Very easy to get impactions. Is that we won't be able to hear as well. Now, my husband gets this all the time. So once or twice a year, he'll clean his ears out, and he says he knows when it's happening because he can't hear as well, and he'll feel this clacking. And sure enough, I'll watch him, and he does lavage. He irrigates it, and he'll hold his ear over the sink, and it looks like rocks falling out of his ears. So that's why he gets that clacking noise, I guess. Also, it's important if you go to lavage your own ears, make sure you use warm water, not hot, but warm water. If you don't, it'll make you dizzy. Cold water will make you dizzy real fast. Just add to your knowledge there. That ringing in the ears, tinnitus, and dizziness can also be caused by that impaction. And if the impaction, a lot of times when you see, if you can go out and look at YouTube's where videos where they are cleaning out these impactions, and the inside of the ear will be raw and sore because of that impaction being there. And they could have other things going on as well. So it just more or less tells you how they remove in this paragraph, but the mechanical removal is also instrumentation. You'll also hear them use the word crocodile forceps, speculum wax hooks, whatever they're, whatever they like to use. And they have to, of course, be able to remove that buildup of cerumen. If may not be impacted, but might have too much in there to where they can't visualize the inside of the ear or the tympanic membrane. Now, note though that especially for Medicare, if you're going to use code 69210, impacted cerumen, there better be a comment in the note that states that the ear has an impaction. Okay, because you don't remove impacted cerumen if there's no impaction. You do something else, right? So it has to state that it's impacted for you to use 69210 for Medicare. Okay, it has to be written in the note. Oh, here we go. This is the really, really gross one that I pulled out for us. I know you're probably telling yourself, "Oh, great, yeah, this is no fun at all." But 31231 is that nasal endoscopic diagnostic, and it can be unilateral or bilateral. We don't have to worry about the laterality in this, but know that when we're just going to visualize, we got to go in and look and visualize that nasal passages. A lot of times they'll put just the anesthetic in there. They also can put in a vasoconstrictor that clamps everything down. They use this little telescope that goes in. It's rigid endoscopic or flexible endoscopic. They go in and they look at the inside of the nasal passage to see if there's any abnormalities. This is a really, really common one, but don't get this code confused with the previous code that we talked about because they are different. This is nasal endoscopic. They go and look at the larynx, that's a different code. If they go in up and look at the sinuses and stuff too, you know, then we're looking at different codes. Some of the anatomy that you're going to see in the procedure and the notes are going to be vestibule. So a vestibule is just the opening right outside, right inside the door. If you have grown up in an old church, they would say, hey, I'll see you in the vestibule, meaning just as soon as you walk in the door, that's the vestibule, a little separate area. The floor and inferior meatus was next. Then the let's see if I can say this, cephalethmoid recess. They'll look at that frontal recess, middle and superior meatus, middle and superior chona, and internal nares, which your nostrils are your nares, if you didn't know that, and nasopharynx could be examined by doing this. The sometimes they'll put a, you know, they'll save the images, you know, digitally, but don't spend too much time looking at this graphic that I pulled out, because if you do, you can identify what that is in that person's nasal passages. So put in the chat what you think it is, what it is, and at the end we'll look and see if who was right and who wasn't. Let's see. Therese from LinkedIn says this procedure requires a modifier. Yes, there is modifier usage with these. Yes, thank you. I didn't mean to say that incorrectly. I appreciate that. So 31231, you have to know that it's diagnostic, that there's unilateral or bilateral, and it's a separate procedure. Now, let's talk about some pictures here that I saved for you. This particular picture right there is if we are going to irrigate or do lavage for cerumen. This is very common to what the device looks like. Sometimes there's also a little cap on the end of there so it can't splash back at you. This other picture would show actually how deep that goes into the ear. Okay, that, you know, and especially like if you have hemorrhage and stuff, it's the eardrum, you know, it's back here, but that's all the way back here into the cheekbone. There is some impaction of cerumen. Thought I'd share that with you. And I thought when I made this bigger that the little comic strip would be easy to see. I'm sorry about that, but I'm sure that if you Google image cerumen in the ear, you'll be able to see this comic. But it states, now let's see if I can see this without my glasses. I'm looking around. It's like, of course I don't have my readers around me. It says Gandalf, the otolaryngologist. Why do you interfere with my efforts to protect the middle ear? And then it says, cerumen the wet, you have grown too large and interfere with hearing, you shall pass. So again, that would be a crazy little joke there, of course, right? Jay Meyer said, would you add modifier 59 with 31231? You know what? There's better modifiers now. 59 isn't what's used. You might use like a XS or some of those others. XS is, I think, the one that I remember using with that. So modifier 59. What I would encourage you to do is Google the code. Google 31231 and then say modifier 59 usage. And I bet if you go back, gosh, when did that go into effect? Was that 16, 17? I don't know what year they did it, but then you'll get those other modifiers. Yeah, and we've done videos on these other modifiers. So you can definitely go to our YouTube channel and just when you type in the search, just put like XS or XU and you'll get those other modifiers. I call them X modifiers. Yeah. because I couldn't quite tell what the object was. Yeah, that's supposed to be an earwax and a monster, I guess, and then the Gandalf, the ear doctor, the ENT. So again, kind of funny. Now, some other things that I want to just highlight and talk to you about is other things that you'll find useful. So I'm going to bring over a screen I really, really like here. Now, this is a particular ENT provider group. It is in San Mateo, California. But what I liked about them is, one, they talk about the different organs that they work with, but you can go up here and look. They look and they have hover allergic rhinitis. Okay, so you can click on that. This is going to really help you with your knowledge base. Um, this is going to help with the ICD. Now, again, this may not work really quickly, but allergic rhinitis or hay fever. And then it talks about it a little bit and gives you some more information about it. So I thought that was great. Here's let's see, cholestoma. I see this on encounters quite a bit, especially for older people. But any of these terms that you may not be familiar with, oh, we're going to ignore that. But it talks about that. So let me get rid of that. I put it in a resources page so that you can see it. But again, sites like that will give you greater knowledge of the diagnoses or why they do what they do or specialties, and maybe even some great graphics to help you. Now, another site that I absolutely love with doing ENT work that you should be aware of is Novitas. They again are part of an insurance organization, but specialty exam score sheets, they are fabulous, this particular website. Now, don't worry about having this, it's in the resource page. So if you're in our CCO club, of course, you'll have access to all those links. You can use the 95 or 97. And then what they did was they've got all these specialties. So you can go to ENT and then just hit the PDF or the HTML, and it'll allow you to get a specialty NEM scorecard so that you can level your E&M. So much easier. And of course, they've got these others that they use, but well, let's just see if I can bring that up without too much difficulty, and we can look at that real quick before we end. And again, common codes for ENT that you will see. However, we didn't talk about any of the E&M because E&M is used by all of these providers, right? All these specialty groups in the outpatient arena. But sometimes it's difficult to do an E&M with specialties when the review of systems is so small, right? Of course, we're not looking at all of the body. The exam tends to be an area that we struggle with. And so what they did was brilliant for us. So we know if we've got 1 to 5 bullets, we've got a problem focus. 6 to 11 bullets, expanded problem focus. 12 to, or more bullets is detailed, and at least 1 bullet in each box with an unshaded border. Of course, this is a shaded border. This is unshaded border. And every bullet in each box with a shaded border. So that's every one of these was mentioned. You don't get a lot of comprehensive in regular ENT, maybe if you got some subspecialty or something. But again, let's look at this. They might identify something with respiratory, cardiovascular, lymphatic, and neuropsychiatric. Again, could be used, but this is what you're going to see the most in these exams: the ear, nose, mouth, and throat. And they will say, inspection of nasal mucosa, septum, and turbinates. inspection of lips, teeth, and gum, examination of oral pharynx, oral mucosa, hard and soft palates, and exam, and and what are they looking for? Asymmetry, lesions, hydration of mucosal surfaces, meaning the is the inside of the mouth dried out? We have we are dehydrated. Let's see, inspection of pharyngeal walls and piriform sinuses, pooling of saliva, asymmetry or lesions. Oh, examination by mirror of the larynx, including epiglottis and stuff like that. And then let's look again. We went over that quickly. Constitutional. 3 of the following 7. Sitting or standing, blood pressure, supine blood pressure, pulse rate and regularity, respirations, temperature, height, weight, and measured, and of course, ancillary staff. So again, you usually have those vital signs. So that'll give you 3 of 7 right there. Head and face inspection. Yeah, you got to have 3 of them to count as 1 bullet, sorry. Inspection of head and face, overall appearance, scars, lesions, masses, palpitation and percussion of face. Why would they do that? They're sinuses, that's hollow, right? Examine salivary glands, facial strength, neck, for masses, overall appearance, symmetry, tracheal position, midline, trachea, midline, you'll see them say that. Examination of the thyroid. Is there any masses, nodules, or anything tenderness, that they can feel? So these are things that would be addressed that would allow you to help level your E&M. And then it would tell you, this is for the exam, if you've got the 1 to 5 bullets, et cetera, et cetera. So I thought this was excellent. You can download those and you don't have to just do one specialty. This is a great website to have these other specialties, and it helps you with the verbiage, which is extremely important when you're abstracting or first learning how to read the documentation. So I think that's really, really helpful. So let me get rid of that for you. And again, that link is there. Okay, that's it, guys, I believe. So I want to tell you again that my purpose tonight was to give you kind of a launching point of ENT to do your own research, some of the common procedures that you'll see done daily in an ENT's office, and maybe talk about modifier usage a little bit, and as well as that launching point to, now let's go look at the diagnoses that we would see. Let's look at what I would like for you to go and look at NCCI edits. Can we use one of these codes with another code? Some of them you can and some of them you can't, right? So take some time to do that. Do some YouTube videos on cerumen impaction and them cleaning the ear out, the ear canal. Perforated tympanic membrane or eardrum. I would visualize that. What are the signs and symptoms of some of the conditions that we need to look at? When you're coding, we need to know the sign for outpatient. You need to know the signs and symptoms of allergic rhinitis, right? Because if they have a diagnosis of allergic rhinitis, you're not going to code those signs and symptoms. Don't forget things like dizziness, GERD, that could be associating to other problems in that an ENT might focus on. Let's see, I think that's about it. So I'm really curious to hear if you've been exposed to an ENT or someone has, and common things that you remember that they did in the evaluation, different things that were asked and talked about or covered, and share them in the CCO club. It's not all about having questions answered. It's also about sharing knowledge or unique experiences. Maybe you or know somebody that had, like I said, a bean or something stuck up in the nasopharynx from pushed it up so far, and what was the outcome of that? Tonsillectomies, adenoidectomies, you know, what is involved in putting a myringectomy, putting the tubes in the ears. So, because we didn't even cover that, because that's usually done on the procedural end at the hospital, but they're definitely evaluated in the ENT's office. All right. Thank you very much, guys. And don't forget to like and subscribe. And thank you, our new friends on LinkedIn. We're so excited to be able to have you join us. This is new for LinkedIn to be able to live stream. And we've been live streaming for several years, but again, it's fun to have LinkedIn join us. And LinkedIn, you can share the videos and you can share them in YouTube as well. There is the resource pages that I talked about. Some of those are just the pictures, but that last one was that Novitas that was brilliant. So take time to add that to your bookmarks for future. All right. Thanks, guys, and have a great rest of your day.